In this series of 3 videos, I'll be covering the competency describe the role of oxidative stress in the pathogenesis of conditions such as complications of diabetes mellitus, cancer, and atherosclerosis. In this video, I'll discuss how the oxidative stress is involved in the pathogenesis of complications of diabetes mellitus. Diabetes mellitus has been of interest because of its global presence and a significant population of most of the countries is suffering from diabetes mellitus. At present, diabetes mellitus is only managed and there is no cure. Diabetes mellitus is a metabolic disorder which is characterized by elevated blood sugar, which is called as hyperglycemia. Hyperglycemia can result from defect in insulin production and or defect in insulin action. Defect in insulin action is also called as insulin resistance. So due to decreased insulin production or due to insulin resistance, there occurs a reduced tissue uptake of glucose, which result in intracellular hypoglycemia and extracellular hyperglycemia. There are number of evidences that suggest significant contribution of oxidative stress in the initiation and progression of diabetes mellitus and its associated complications. Oxidative stress is an imbalance between reactive species, which is also called as free radical, and antioxidants. The imbalance may be due to enhanced production of free radicals or the depletion of antioxidants. High levels, there are various types of free radicals like reactive oxygen species, which include superoxide, hydroxyl radical, peroxyl, alkoxyl radical, hydroperoxyl radical. There are also reactive nitrogen species, which include nitric oxide, nitrogen dioxide. Reactive chlorine species include atomic chlorine. High levels of free radicals can damage lipids, proteins, nucleic acids. Moreover, hyperglycemia in diabetics can stimulate free radical production. And when the defense system of the body becomes impaired, it is unable to neutralize the excessively formed free radicals or reactive oxygen species in particular, resulting in an imbalance between reactive oxygen species and cellular protection mechanism, that is antioxidant. This may cause oxidative stress on cells and may lead to inflammation, formation of advanced glycosylation end products, which is also called as AGs, oxidation of various macromolecules, including oxidation of low density lipoproteins, and may cause insulin resistance. All these events may lead to the development of diabetic complications. Free radicals may also trigger various signaling pathways inside the cell and alter gene expression that may cause cellular injury. In diabetes mellitus, possible sources of oxidative stress include non-enzymatic glycation of proteins, amino acids, lipids, nucleic acids, auto-oxidation of glucose, shifts in the redox balance, decreased tissue concentrations of antioxidants such as reduced glutathione and vitamin E, and impaired activities of antioxidant defense enzymes such as superoxide dismutase and catalase. Persistent hyperglycemia in diabetic patients may cause macro as well as microvascular complications. Macrovascular complications are due to damage caused to larger blood vessels, and it includes coronary artery disease, peripheral artery disease, and stroke, whereas the microvascular complications are caused due to the damage caused to smaller blood vessels. It includes diabetic nephropathy, neuropathy, and retinopathy. Now I'll explain the coronary artery disease, one of the macrovascular complications of diabetes mellitus. Coronary artery disease is caused when atherosclerosis affects arteries that supply blood to heart muscles. Atherosclerosis is a disease in which plaque builds up inside the arteries. Arteries are the blood vessels that carry oxygen-rich blood to heart and other parts of the body. Plaque, this is the plaque that builds up in the arteries, is made up of fat, cholesterol, calcium, fibrous tissues, and the other substances found in the blood. Diabetes mellitus significantly changes the lipid profile. Patients with diabetes mellitus have elevated levels of triacyl glycerol, low levels of HDL cholesterol, and they also have abnormalities in the structure of lipoprotein particles. It is well established that hyperglycemia stimulate free radical production, and this is the reason why the LDL oxidation in diabetic patients is significantly increased as compared to healthy humans. As compared to native LDL, oxidized LDL is much more atherogenic, and the oxidized LDL is also recognized by the immune system as foreign. This figure is showing various layers of blood vessels. This is endothelium, this is tunica intima, this is tunica media, and this is tunica adventitia. This will help understand the changes occurring during the course of coronary artery disease. Atherosclerosis in general and coronary artery disease in particular may occur either due to high level of low density lipoprotein, or due to build up of oxidized LDL, or due to the damage damaged endothelium. See, the endothelium do not normally express the cell adhesion molecules, but high levels of native LDL, or the presence of oxidized LDL, or the dysfunctional endothelium causes the enhanced expression of cell adhesion molecules on the surface of endothelium. Once the cell adhesion molecules are expressed on the surface of endothelium, it causes the recruitment of leukocytes, monocytes, neutrophils, T lymphocytes, and mast cells on the surface of endothelium. These cells then migrate into tunica intima. Monocytes, once into tunica intima, differentiate and mature into macrophages. And the macrophages, they express scavenger receptors, and they efficiently take up the oxidized LDL and become foam cells. They are called foam cells because of their foamy appearance. They are called as foam cells because the lipoproteins give the cell a foamy appearance. The presence of foam cells in the arterial wall is a hallmark of early atherosclerotic lesion. Leukocyte, mast cells, neutrophils, T lymphocytes, they also migrate into tunica intima, and along with the foam cells, they releases variety of cytokines that promote inflammation and reactive oxygen species generation. And they also release growth factors. Growth factors released from neutrophils, T lymphocytes, foam cells, as well as the reactive oxygen species, causes the stimulation of smooth muscle cells, which then migrate from tunica media to tunica intima. And this is followed by the increased synthesis of collagen, lead to the hardening of the atherosclerotic plaque and collagen deposition, leading to the development of erythematous plaque. During this process, the foam cells, they die and the plaque grows. Rupture of the plaque lead to the formation of thrombus. All these episodes occurring here instigate the formation of atherosclerotic plaque. Moreover, hyperglycemia in diabetic patients also causes the glycation of low density lipoproteins, and as compared to native LDL, glycated LDL is much more atherogenic. In addition, diabetic dyslipidemia promote endothelial dysfunction that affects vasodilatory, anti-atherogenic, anti-inflammatory properties of endothelium. Peripheral artery disease is another macrovascular complications of diabetes mellitus. Peripheral artery disease is an atherosclerotic disease. Peripheral artery disease is very similar to coronary artery disease, except that it affects the arteries that supply blood to legs, stomach, vital organs, arms, and head. Peripheral artery disease mostly occur in the arteries of leg. And other macrovascular complication of diabetes mellitus is the stroke. Stroke is caused by a blockage in an artery that supplies blood to brain. The blockage reduces the blood flow and oxygen to brain, leading to damage or death of the brain cells. Although oxidative stress has been implicated in numerous pathologies, but brain is particularly sensitive to oxidative damage because of the high consumption of oxygen by the brain cells under basal conditions. Brain cells have high concentration of peroxidizable lipid. High level of iron in brain act as pro-oxidant during a stress situation. Now I'll discuss the microvascular complications of diabetes mellitus. In this, the first one is diabetic nephropathy. Diabetes mellitus is the leading cause of chronic kidney disease, which is abbreviated with CKD. Hyperglycemia is associated both with the generation of free radicals and the formation of AGs. In turn, AGs are also associated with the generation of free radicals. Both these conditions causes oxidative stress, which causes vascular abnormalities. Vascular abnormalities are the abnormalities of blood and lymph vessels. Moreover, generation of advanced glycation end product creates pro-inflammatory state, and all these changes promote diabetic nephropathy. Sustained hyperglycemia in diabetes mellitus causes progressive structural changes in mesangium, glomerular basement membrane, and tubulointerstitial tissue of the kidney, and is considered as the driving factor for diabetic nephropathy. The progression of diabetic nephropathy is complex and multifactorial. The persistent hyperglycemia in uncontrolled diabetes mellitus results in the non-enzymatic glycation of amino acids, proteins, lipids, nucleic acids that leads to the generation or the formation of advanced glycosylation end product. And we know that the formation of advanced glycation end product is associated with the generation of free radicals. Free radicals that are generated causes the modification of basement membrane proteins, cross-links extracellular components, increases expression of type 4 collagen. All these alterations lead to structural changes in proteins, such as changes in the net charge on the protein, which is called as surface charge of the protein, affects membrane permeability, proteolytic digestibility, will cause changes in membrane stability, and also disrupts intercellular interaction, thus causing impairment of tissue function and maintenance. Diabetic retinopathy is also a microvascular complications of diabetes mellitus. Diabetic retinopathy, a disease of retina, is the leading cause of acquired blindness. Hyperglycemia results in the generation of reactive oxygen species. Hyperglycemia causes the glycation of proteins, nucleic acid, and lipids, which results in the generation of reactive oxygen species, finally leading to oxidative stress. Oxidative stress causes various physiological, structural, and functional abnormalities, leading to diabetic retinopathy. Continued high circulating glucose in this long-lived disease can damage retina. Retina has high content of polyunsaturated fatty acids and has the highest oxygen uptake and glucose oxidation relative to any other tissues. These features renders retina more susceptible to oxidative stress. Hyperglycemia, changes in the redox balance, and oxidative stress are the key events in the pathogenesis of diabetic retinopathy. The retina of diabetics have high level of superoxide and hydrogen peroxide, and also have the elevated level of product of membrane lipid peroxidation and oxidative damage to DNA as the consequence of reactive oxygen species induced injury. Due to hyperglycemia, the microvasculature of the retina is damaged. Also, the blood vessels swell and fluid leaks. If it is not prevented, angiogenesis takes place, which ultimately lead to the detachment of retina. The capillaries of retina are lined with endothelial cells. The function of the endothelial cells is to maintain the blood-brain barrier. These endothelial cells are supported with the equal number of pericytes, and the function of the pericyte is to provide tone to the vessels. Normally, the ratio of the endothelial cells to the pericytes is 1:1. But in diabetes, the ratio of endothelial cells to pericyte is altered to 4:1. The blood vessels of retina have tight junctions that protect them from leaking. But sustained hyperglycemia in diabetic patients damages the tight junction and the vessels become leaky, allowing fluid or blood to seep into the retina, thus causing the swelling of the retina. Due to progressive dysfunction, the capillaries die prematurely, leading to ischemia that can be followed by neovascularization or angiogenesis and ultimately retinal detachment and blindness. Another microvascular complication of diabetes mellitus is diabetic neuropathy. Hyperglycemia stimulate the generation of reactive oxygen species. Hyperglycemia can glycate various macromolecules, resulting in the formation of advanced glycation end products, which is associated with the generation of reactive oxygen species, thus causing oxidative stress, and the generation of reactive oxygen species causes nerve hypoxia. All these things together cause neuroinflammation, neuroinjury, finally lead to the development of diabetic neuropathy. Signs and symptoms of neuropathy are often worse at night. So why neuropathy worse at night? Though research hasn't confirmed the exact reason, but there are few scientific guesses. When one is trying to sleep, it is often necessary to quiet your mind, to rest and to take a break from the distraction of the day. However, the normal events of the day may be helping keep the mind off the neuropathy pain. But when one is lying in the dark and less distraction, and it may be more difficult to not focus on the pain one is feeling. The signs and symptoms of neuropathy include numbness or reduced ability to feel pain or temperature changes, tingling or burning sensation, sharp pains or cramps, muscle weakness, increased sensitivity to touch. For some people, even the weight of a bed sheet can be painful. The pathogenesis of diabetic neuropathy is not fully understood, but several risk factors are known to be associated with diabetic neuropathy, like older age, longer diabetes duration, alcohol consumption, and cigarette smoking. a vast array of molecular pathways such as PKC signaling, TNF-alpha signaling, GSK3 signaling, polyol, hexosamine, AGs, PARP, MAP kinase, NF-kappa B, hedgehog, cyclooxygenase, lipooxygenase, Venn pathways. In addition to that, oxidative stress, interleukins, nerve growth factor, and autophagy have been implicated in the pathogenesis and progression of diabetic neuropathy. You just have to remember the names of these signaling pathways or the other pathways. You don't have to go into the details of these pathways. Thank you.